Okay, I'm so sorry. I apologize for holding everybody. I'm just ready to start now. Kalpana, just reconfirming everything is okay and you can hear me well.
Yes, we can, and we can see your slides well as well.
Okay, all right. Sorry. So we'll start. As usual, we always start with a traditional history, and we must always know what is kind of what has happened, because history is the real pillar of what we are doing today. So basically, it was 1855 when cocaine was first discovered, and it was isolated chemically and from a coca plant, and people realized that in 84, it took them 30 years to realize that this had a local anesthetic property, because in 84, an Australian ophthalmologist, Carl Collar, instilled 2% cocaine into his own eyes and tested its effectiveness as local anesthetics by pricking the eye with a needle. It was actually 1885, immediately after this experiment, that James Conning, he injected cocaine between the spinous processes of the lower lumbar vertebrae, first in a dog and then in a healthy man. And he published this experiment as neuraxial block. But it was actually in 1898 when August Bayer, he injected and did a surgery. It was the first spinal anesthesia that was given. However, there is some interesting fact that there is no doubt that Corning performed his experiments before those of Bayer's. However, for many years, there was a controversy that who actually did the first spinal, or whether Corning injection was a spinal injection or was an epidural. However, when the dose of the cocaine by Corning was compared with that of Bayer, it was 8 times higher. And despite much higher dose, the onset of analgesia in Corning's experiments were slower, and the dermatome levels had a lower sensation. So it was then concluded, and also Corning did not describe any fluid coming out of the needle or any kind of this kind of reports. So based on all these things, it was reported and concluded that Corning was the one who gave the first epidural block, and it was August Bayer who actually gave the first spinal anesthesia. Just some interesting fact I thought would be for people to just kind of have some interest in the spinal. So this was a little question, but then finally it was answered. And when we were residents and we were giving exams for final MDs, just for the residents, we never had heard of August Bayer. And we had a short note called Bayer's block. And everybody was confused whether to write the IVR or spinal anesthesia. So just to understand and to know what is the right wording. Okay, the ideal lecture plan would be, going through all these titles, and that's absolutely going to be impossible because this is like a little full textbook on spinal anesthesia. So I'm only going to pick up some important points, and that I kind of am going to try and highlight what is important in that. When you talk about indication, I'm not going to go into detail, but one most important point I want to highlight, and that's the first contraindication, which is an absolute contraindication, is patient refusal. For residents, it is very, very important that they must understand that you must respect patients' own wish and will. And in today's day of medical legal world, you must absolutely document, even if the patient is not fit for general anesthesia, or if there is a strong indication to give a spinal anesthesia, but if the patient refuses, you must not give a regional anesthesia. You may try and convince, but ultimately it is the patient wish. And if the patient decides not to take the spinal anesthesia, you may not give it, and you may document it, but you must not give something against patient's wish or refusal. So that's something very, very important. I don't know if even the seniors remember, but about 6 or 7 years back, there was a major case reported in the newspaper that a patient refused spinal anesthesia for a cesarean section and in a suburb of Mumbai, and she was poked 6 to 7 times to give the spinal anesthesia, and she ultimately ended up with a paraplegia. So irrespective of what the complication, and that we'll talk about later, but my point is, it is very, very important that one respect patient's wish. Okay, I'm putting this slide only for the residents to highlight and make an important point that do not take spinal for granted. Spinal does not mean that the patient doesn't need to be prepared from the general anesthesia point of view. The starvation, the pre-anesthetic check, anesthesia fitness is absolutely mandatory. The WHO pre-operative, pre-procedural timeout is also a mandatory thing, and one must not take things for granted. The new thing that is coming up and will be kind of a future when you people practice is pre-procedural ultrasonography. We are struggling at Bridge Candy yet to get the USG in the OT, but sooner or later, all the neuraxial blocks would be performed under USG, and you as a resident would have to kind of remember this and make yourself comfortable with USG guided blocks. I'm glad actually that Salman, one of our residents, is trying to look into this thing and doing a pre-procedural USG for a spinal anesthesia, and let's see what he kind of is able to give us in his okay. Another thing, important thing is that spinal, today you people are working in a corporate setup, in a hospital setup, and everything is available. Tomorrow you start going into smaller areas, smaller places. You may be doing an anesthesia in a smaller nursing home. Wherever you practice, it is extremely important that two requirements are met. Number one is a sterile and aseptic environment. You do not give spinal in any place with and compromising the sterility. Felicity Reynolds had a very, very nice editorial written about risk of infections and other things, and she said that remember, and it's a very important sentence that she said, remember that it is somebody else's spine at the tip of your needle. So it is extremely important that you respect and make sure that you are not performing spinal and compromising sterility. And second is, you cannot do a spinal in a place where GA cannot be given. A lot of places, a lot of people say, no, I can't give GA here, but I'll get the case done under spinal. That is not acceptable. You must have all your monitoring and resuscitative equipments available at your disposal when you're giving a spinal anesthesia, and you should be prepared. You should be prepared to convert that case into general anesthesia at any given time, or resuscitate that patient with all resuscitative equipment at any given time. So it is extremely important that you people remember and realize that these are minimum and mandatory requirements for giving spinal anesthesia anywhere. Now, I'll come to my talk now. This is all little theory gone now. Now, I have realized that of late when the residents are with me and when we have given spinal, when I ask them to write the notes, they're looking at their mobile and they're copying something from the mobile. And I wonder what is going on. Because I'm very particular about what I write in terms of documentation with the spinal anesthesia once I've given the spinal. Apparently, I have realized that they've taken a photograph of my note somewhere and it is circulated among them. So whenever they are with me, they kind of try and copy that so that to get a brownie point and say that no, sir, we've written the right notes. So this is normally what I write. Yeah, and it's a little long but continuous sentences and all. So I tell them that you don't need to copy. You don't need to really remember what is to be written, as long as you are mindful of what is doing. Now, when I say mindful, people can be mindful of many things or can be mindful of one thing. And it is the mindfulness which is really, really important, because it improves your concentration and improves your success. So what I tell the resident, that instead of copying, if you just realize what you're doing, and when you're doing things, if you're mindful about it, then it is very easy for you to write what I want you to actually emphasize and write down. And here is what I actually am trying to write down. These are the points which are important when you write a document, when you document your spinal. And I'll now elaborate on each of this point, telling you why is it important, so that one can understand how the spinal is practically be given. Now, you must give spinal anesthesia at a level L3, L4 and not higher than that. And let's talk about that why. I'm not going to go into the anatomy. These diagrams and everything can be seen and everywhere. However, I am going to focus on one point, and this is where I want to focus on. If you see, when we kind of look at the spinal anatomy, where does the spinal cord end is very important. So if you see, just having kind of, it usually ends at the level of L1, L2. However, or in lower border of L1, or sometime up to upper border of L1, L2. So if you give a spinal in a L1 and L2 space, you are most likely to damage the conus and cause cauda equina syndrome or cause major nerve damage. So the recommendation is to give it in L3, L4 space. Now, why is that? Why not L2, L3? Now, the reason you don't give it in L2, L3 is that there are 58% of the normal adults who will have tip of their conus at L1, as we've described, but that means remaining 42% will have it lower than the lower border of L1. And of this, 19% have their conus extending up to the lower border of L2. So if you were to give spinal in a L2, L3 space, there is a chance that you will cause direct trauma to this conus. And hence it is extremely important that you identify and you kind of don't go into the space higher than L3, L4 or L4, L5. The compromise people make is they think that if they go into lower space, they may not get a good block height. And that's why they try to go into a higher space. But one has to be extremely careful when you going into higher space. There is another article from, again, Felicity Reynolds. She's done extremely fantastic job in this area. And she said that why is it important to identify the right space? Because you see what happens is 90% of the time, most of the time, we go by the palpation method. And toughest line is what we try and identify with. It is absolutely inaccurate to follow the toughest line. And because people don't have enough experience and skill, they tend to misread or misidentify your vertebral level. And that's what causes, people to go into the wrong space or cause neural damage. There is also anatomical variation in people with conus, as I explained to you. And also, when you say about we are using atraumatic spinal needle, those needles are also not risk-free. So the needles can, because originally those cutting needles they were saying that they would cut the nerve fibers and cause more damage than an atraumatic spinal needle, but you can still puncture a solitary nerve fiber and can cause neural damage. So basically, it is very, very important. And surprisingly, a lot of textbooks also don't kind of put highlight on this point, and they say that any level spinal can be given after L1, L2. And that's why, in fact, in her editorial in the end, she said L2, L3 space should not be an option, and several textbooks need to be rewritten to allow for human variability. Now, when she says that, there is a fantastic paper which has looked at 4 experienced anesthetists who looked at 100 patients, and they were asked to palpate their spine and identify the correct L3, L4 level, or where they would give their spinal anesthesia, and see what they found. All these numbers with underline are the correct placement. So if you see those people who thought that they were in L3, L4, only 13% of them were correct, whereas 45% were 1 space higher and 24% were 2 space higher. So if you see, effectively almost 70% of the time, you are higher than where you think you are. You see that? So it is extremely important that you identify. This was also proved by another study, which the previous study was checked on MRI in the earlier days. Nowadays, USG is available. So there's again revalidation that almost 40% of the time you are 1 space higher than the above, or than what you think it is. So it is extremely important that you identify the right space before you give this spinal anesthesia. So now that brings us to how do you identify the L3, L4? Obviously, in today's day and age, when a resident is asked a question in the exam or at any stage, the answer is, I will use pre-procedural ultrasound. However, as I said in the beginning, if we don't have it easily available at Breach Candy, I'm sure it's not going to be an easy thing across the country and in a smaller setup. So then what is the right approach, and what do I follow? There was a nice editorial by David Bogod saying keeping in the Reynolds zone. Reynolds, again, Felicity Reynolds, whose article I just showed you, and she insisted on being in this line. And he's kind of done a study, and he's then put an this editorial where what they did was he actually came up with a little rhyming. Says, fill a space, down 1 place, bone pokes, go down 2. So what he says is that when you use your toughest line as your landmark for identifying L2, L3, L4, if you feel a space exactly, don't take that space, go 1 space down. And if you feel a bone in that place where you feel your toughest line is passing, you go 2 space down. So don't go immediately under the bone, leave that space and go 1 space down. And following this, when they did a survey and they checked, they found that almost 90% of time they were all right. So this is like a little practical thing that I always insist with my residents when they're with me, that if you feel the space, don't jump into that space and go 1 space down, and that is much more safer. So that is about where would you give a spinal. Now, then whether you will give it in a sitting position or whether you will give it in a lateral position. So you must write down in your document that I've done it in sitting position or lateral position. The reason being that will help us, or rather help you in longer term, to assess the spread of the block, get the height of the block, side of the block. Plus, it is important that you understand the anatomy and understand what is important when we're giving this block. Before I give my spinal, I always talk to the patient and show them this little kind of diagram which says what position is expected from them. It's a very simple thing. I'm not going to go into detail, but it is very, very important that they understand what is expected from them, because a lot of time people, the patients, in order to try and help you, they actually do the opposite, and they kind of sit straight as if, yes, I will not move. And that's not what is expected. So you must try and have some kind of a little communication and pre-op talk to the patient when you kind of discuss them, and always make them bend and in their bed, in the environment, in the room where they are most comfortable. Because, you know, when they are sitting on the OT table and you say bend and all, they're extremely scared and they'll become tight. But in the room, in presence of their, family members, if you tell them this is what is expected, this is how you're supposed to curl up, or this is how you're supposed to do, it just makes that easy. Also, it is important that a resident should learn both the techniques, lateral position as well as sitting position. Though sitting position is technically easier because you get a better orientation and it is easy to identify midline. Patients are more comfortable sitting up. It's easier to puncture. There is a question mark that because when the patient is sitting up, there is increased hydrostatic pressure, and you may find it easy to puncture the dura, which may not be the right thing you want to do when you're giving an epidural. Or you may puncture a blood vessel. However, it's not really conclusively proven that this is true. So we don't know about that. However, what you must know is that not all patients can sit up. It's very, very important to realize this, that not all patients you can make them sit up. And if you can't make them sit up, you can't do a spinal, you will be in trouble. People who know how to do spinal only in sitting position cannot do it in lateral position. But those who are comfortable doing it in lateral position can do it in sitting position. So it is very important that residents have both the technique mastered. And one more thing, which I realized very recently, just about a few days back, that when I was giving a spinal in a sitting position, patient had a vasovagal and she almost fell off the table. So that's another thing that you have to be very, very careful about. And you must have people supporting the patient and kind of take care of that. So it is very important that you are prepared and you are conversant with both the technique of putting the spinal anesthesia. There was another article in the Indian Journal of Anesthesia a while ago, which says that every time, a lot of time this we give spinal and we keep hitting the bone. And it is very important that you must identify and understand where the needle is hitting. So depend on the depth of the needle where you feel the bone, you must redirect and reinsert accordingly. If the bone is contacted at a shallow depth, the needle is likely contacting the more cephalate spinous place, which is this scenario where you suddenly hit the bone in a very, very superficial. In this case, you got to go caudal and proceeds and direct your needle into the caudal direction. However, if you hit the bone when you are in deep, then you have to try and angulate cephalate. So this is something that I always have kind of told my residents, that they got to be very, very careful in identifying where the needle is hitting the bone. And accordingly, you have to, of course, finding midline is the most important thing, and being in the midline, because sometimes you may be off the midline and then you may find the bone and touch the bone right at the dip, which may be just touching the, one of your laminas, and then it might be at the same level. So that is something that is, you have to be very, very careful, that the slightest angle away from midline and you may have a problem. So you must identify your midline, and accordingly you can change the direction of your needle. The next is in obese patient. How would you give? So many times we get, nowadays with this newer generation, we have lots and lots of obesity becoming a major issue. We have lots of obese patients coming in, especially for us in pregnancy. The pregnancy weight is already put on, they put on weight on pregnancy, and if they are already obese, we have 110, 120 kgs patients coming up for surgeries. So how will you, so what are my advice for being a spinal and obese patient is the use ultrasound, because ultrasound guided can give you exact midline, because in obese patient, it is sometimes very, very difficult or almost impossible to feel any vertebrae. So you don't know where the midline is. However, in sitting position, you may see the midline, because most of the time the center midline still kind of is the least kind of bulky area. So you can make out that there's a little dip and you can pick up the midline. However, you don't know which intervertebral level you are going in and what is the depth that you need to go in. So USG becomes extremely important in situation like this. Sitting position is obviously helpful because you see midline better, and because of the gravity, the weight of the fat on both the side kind of falls on the side, causing a little gutter type of thing in the center, which gives you easier. If you have this patient in the lateral position, because of gravity, the upper size fat will fall down and will distort the midline completely. You may use long spinal needle. Sometimes long spinal needles are not available. What I suggest is you can open a CSE set, because the CSE spinal needles are longer than your normal spinal needle, because they're supposed to pass through the same 10 centimeter length of the epidural needle. So you will have an extra 1 or 2 centimeter when you use a CSE set spinal needle. I'm not saying you should do CSE. I'm just saying you can use a CSE spinal needle. One more thing you can do is that when you're using the regular spinal needle, because as we go along, I will say why it is important, but because a lot of time we use introducer to use this thinner gauge atraumatic spinal needles, it is important that you and that will kind of, keep you away almost by a centimeter from the skin, because the introducer will take that much 1 centimeter before your needle can actually touch the skin. So sometime by kind of pushing or indenting that introducer into the skin, you may generate that 1 centimeter and overcome that little disadvantage of using the introducer. Or sometime people can have done, they give a local infiltration little more in the spinal area, and with a needle just make a little gentle, just small nick. So through that you can actually push your introducer in, or even your spinal needle little in, so that you can get the extra half a centimeter or so. One more practical point is that you must avoid doing cephalad angle in obese patient. Try to go as straight as possible. See what I'll tell you. When we have a thoracic spine, the angulation is almost like a little 45 degrees. But that's not the case in a lumbar spine. In the lumbar spine, you have almost a straight line, or a less of a cephalad, or less of an angulation. If you do Pythagoras principle, the slightest deviation of an angle here from the straight line will increase the length. So obviously the length of the red line is longer than the length of the blue line. So try to be as flat and as parallel to your floor while you are introducing the spinal needle. Again, you will save by a few millimeters in order to get through the spinal needle. It's just some little thing that I've just put this simply because in exams you get a short note called Taylor's approach, and again, if people have not heard of it, what the Taylor approach is, they get completely bounced off. So I'm just put this just simply for the residents to understand and kind of read up, because I'm not going to talk about theory as I said in the beginning. Okay, the next point we're going to go about is asepsis. Okay, now as I said in the beginning also, asepsis is a most important thing. Infection following spinal anesthesia are not as common as one would expect, and which is good for us, but that also makes us complacent and we take things for granted, and that's where the infection can come. Even if the rate is 1 in 1 lakh or 1 in 50,000 or 1 in 2 lakhs, for that one particular patient, it is 100% risk. And it is your primary responsibility to avoid any iatrogenic factor which will increase the risk of infection. So please, again, asepsis is a prime importance. Now, I recommend all the residents to read this article. I am not going to go in detail on this article. This is a fantastic article which was published first time in 2014, and they've just recently reviewed in 2019. And they compare the two most commonly used antiseptic solutions used for neuroaxial block, and that's betadine and chlorhexidine. They've compared and said that chlorhexidine is better than betadine, but in chlorhexidine also they've compared chlorhexidine aqueous versus chlorhexidine alcohol, and they found that chlorhexidine alcohol is a better option than chlorhexidine aqueous, and they've also compared two different concentration of chlorhexidine, that is 2% versus 0.5%. So basically it's a very, very good article. It's a kind of a complete article which will give you the detail of what is the available antiseptic solution. And the conclusion that they're saying that chlorhexidine is better than the betadine because it has a faster onset of action, deeper penetration, it has a longer lasting action, wider bacterial and it's a bactericidal as well as bacteriostatic, and it also has a property to work in environment which are conducive or which are not safe, which are not kind of protected by the iodine, like in terms of patients with, say, there's a bleeding or there's some kind of a thing happening, chlorhexidine can prevent. And so in a spinal anesthesia, maybe it may not matter if you just doing a single shot spinal, but when you're doing an epidural or when you're kind of going to keep a catheter for long term, they recommend strongly that chlorhexidine is something that needs to be used. However, chlorhexidine cannot be taken for granted. It is extremely neurotoxic. Chronic adhesive arachnoiditis is a major neurological complication that can happen if you are not careful. And it's an iatrogenic complication. It's an iatrogenic problem. So while increasing safety of infection or minimizing the risk of infection, which is already very low, if you are not going to be careful about using the chlorhexidine properly, you actually are inviting more trouble and problems, as happened in this case here. This was a very unfortunate incident. I'm trying to tell you these two cases because it's very, very important for the residents to know at this stage what damage chlorhexidine can do and how do you prevent it. This case was a patient in New South Wales, Australia, Grace Wang. She asked for an epidural for a pain relief during her labor. Now, what followed was, it was a difficult epidural. The anesthetist who had washed up for the epidural had taken normal saline in one bowl and chlorhexidine in another bowl. Now, the chlorhexidine is a pink color solution. So two different bowls were kept there. And it so happened that the epidural didn't happen in the first go. It became a little traumatic. So there was a little blood stain. And saline was being used to identify the space. So the saline also in the bowl got a bit pink. So finally, when she managed to get the epidural in order to identify the epidural space, the anesthetist had loaded her syringe with chlorhexidine. So she actually accidentally injected 8 ml of chlorhexidine, considering that it's a saline to open up the space. And this patient ended up paraplegic and is not at the end of, now this is nearly 2012. So this is almost 10 years now. And she's still nowhere near recovery. She's probably recovered about 25-30% of her neurological damage, but she's still wheelchair bound and she's not. The point I'm trying to make and what they have insisted in saying is that when you use bowls to keep your antiseptic solutions, keep them completely away, keep them out of your sight, keep them away. Ideally, we should not use the bowl, but we do not have those disposable swab sticks available. In the US and UK, they have those disposable swab sticks available like a ice cream lolly. You just open the swab sticks, use the swab sticks and throw it away. So there is no liquid lying around anywhere on your trolley, which is dangerous to be injected. So this was something that really kind of caught people's eye, and they realized that this is not something that you have to be careful about. So somebody will say, but this was injection of epidural. No, when we apply on the skin, what is the problem? So here is another case. A lady called Angelique. She again had a cesarean section under what is known as, what is kind of appears to be the most simple, straightforward spinal. She was given 0.5% bupivacaine, 2 ml with 15 mics of fentanyl, just a simple, straightforward spinal. As soon as the spinal was given, she slightly complained of pain on both her legs. And by the time the spinal acted and she didn't kind of say anything, and it all went on. And this is what has happened. This is how she went home after the spinal anesthesia with a baby. Again, this prompted an editorial from David Gogol, who's a medical legal expert in the UK. And he said they went to the thing and they realized that even micro contamination in the previous case, 8 ml of chlorhexidine was injected. Here they postulated that even if 0.1 ml or 0.05 ml of chlorhexidine is injected, you could still have a major neurological problem and chronic adhesive arachnitis with chlorhexidine. So it is extremely important that you keep all your needles, syringes covered while you are using any of your antiseptic solutions. So there are no micro contamination. When the people are pouring into the bowl from a bottle, there are micro contamination that happens, which you can't see. But if the needles are lying around, they may go and drop on the needle, and all these things can cause a severe problem. So the article of the AAGB recommends very, very strongly that even though it is very important, I mean, they primarily recommend, of course, that what I said in the beginning, hand washing, cap, mask, gloves are extremely important. But they have said that chlorhexidine should be used for all central electric blocks. However, it must be important that you keep chlorhexidine from reaching the CSF or into the epidural space. How do they recommend? You should be kept away. As I said, you don't keep it with your syringes and needles that you're going to use. Keep it away from the drapes. You must not. Another most important thing is allowing it to dry. It's a universal time of 5 minutes that you must allow your chlorhexidine to work on the skin and allow it to completely dry. And before you touch your spinal needle or your syringes, you must watch for your hands and gloves and make sure that there are no contamination on the gloves. Again, I want to reiterate one point here. A lot of people have the habit, or residents learn, and they do this, is that when they're giving a spinal, whether they're using chlorhexidine or betadine, they will wash up, they will wear gown, gloves, cap, everything. They'll come and open the spinal trolley. They'll prepare everything. They will get the syringes. They will get the drugs drawn. They'll keep everything ready. And then they will go and apply antiseptic on the patient's back. And once the antiseptic solutions, whichever you are using, say two layers are applied, in the next breath, they will take spirit or alcohol and wipe it off. You must give time for your local anesthetic, for your antiseptic solutions to work on the skin. It has to have a contact time of minimum 5 minutes. It has to dry on the skin to work. So what I recommend and what I do is that when I wash up, as soon as I come to the patient, first thing I do is take my antiseptic solution on the side and apply the antiseptic solution on the patient's back, and then come back to prepare. I am not wasting any extra time. What I've just changed the sequence of event. Instead of doing the preparation first and then applying antiseptic, you apply antiseptic first and then do your preparation. It automatically gives that much time for the antiseptic to work on the skin and dry, and then you can always wipe off. Okay, so this is something that is very strongly recommended here, that you allow it to dry and give up proper contact times and make sure that there are no contamination of your gloves when you are giving. And what they say that even though US, they are using 2% chlorhexidine, the UK practice is to use 0.5% chlorhexidine, because they found that both had almost similar profile in terms of preventing infection. But obviously the risk of neurological complication and chronic adhesive arachnitis is higher with 2% chlorhexidine. So they recommend 0.5%. Okay, so that's to do with the antisepsis. Now let's talk about what needle will you use. Sorry. Now I use 25G Whittaker. Okay, now just basically conventional teaching, when we were resident, we were all taught to give spinal with 22 and 23, and if you could do it with 23, you had to give a party on that day to the whole unit or the OT people with whom you're working. However, nowadays the reviews and the whole idea of worry about the needle size is to do with post-dural puncture headache. And there are enough evidences now to suggest that the lower the number, or rather lower the gauge, or the higher the gauge number, is the less is the PDPH incidence. So, what I normally use is 25G Whittaker or 18G as far as epidural is concerned when I'm doing an epidural. Another question, another issue was, I'm going to come on the size of and the bevel, the needle design a little later once again, but just going through this flow. Again, when we were residents, we were told that you have to give a spinal with bevel facing parallel to the dural fiber, because in those days, the light electronic microscope study showed that the dural fiber ran into parallels. So if you were to kind of go parallel to the fibers, you will not be cutting the fiber, but you will just be splitting the fibers. However, the recent with electronic microscope review, it shows that the dura is a multi-layer structure and it's a crisscross structure. So what appears to be just running vertical on the superficial layer is not the same through the depth of the dura. So irrespective of whether you give, needle straight, bevel facing lateral or bevel facing forward, you should not rotate the needle inside, because that is what causes the damage. So you should avoid rotating the needle. Which way you face the bevel is not really important, especially depending on what type of needles do you use. When needle designs are concerned, obviously, originally we were all using the cutting type of needle. However, the recent recommendation and reviews are showing that atraumatic or pencil point needles are better. There are various needles available, of which 25G Whittaker is my favorite. And again, various size, when you're using different designs, the risk of post-dural puncture headache with Whittaker design is least compared to Sprott or a Quinky that normally people use. These are the various designs which I always ask my resident to draw, because you must understand how the needle tip is there and where the opening and bevels are placed, because that helps you in preventing failed spinal, which I'll talk to you a little later. So in my practice, I usually I use 25G Whittaker. Here are some, general diagrams and photos which says that generally, people feel that the PDPH is because of a loss of CSF through a hole left in the dura. These are various photographs of various kind of holes, but this is what is important, that when you kind of give a dural puncture with a Quinky or a cutting needle, it forms this kind of a split in the dura, as opposed to when you use a Whittaker pencil point needle, it leaves a very tiny hole. And this is how it is seen from inside also. When you go with a Quinky needle, it causes this kind of a rugged and a flap wall kind of a thing, as opposed to when you use a 25 gauge non-cutting needle, it's a clean cut and it comes out cleanly. So what is the final recommendation is, if you're using 29G, fine, you can use whichever needle you want to use. However, it is a 25G Whittaker, which is equivalent to 27G Quinky. So whichever needle you are comfortable with, you must use that needle. However, you must know that you cannot compare 25G with Whittaker with a 25G Quinky, because there the risk of post-dural puncture is higher. Recently, one very interesting study has come out on this issue. And what they have done is they have compared 11 different needles in a 61 randomized controlled trials, including almost 15,000 patients. And they've checked two things: probability of PDPH and risk of procedural failure, because the smaller the size of the needle, the higher the chance of failed spinal because of the technical difficulties. So they have found that when they went through this different 11 types of needle, I've only picked up 5 which is commonly available and which we may want to use. they have found that 26 number atraumatic pencil point needle are the best both in preventing PDPH as well as minimizing the or improving the spinal success or minimizing the risk of failure. In my practice, as I said, I use 25G atraumatic, that is Whittaker, which is definitely is what is available as far as PDPH concerned. None of these needles are available, so I'm very much comfortable using this. As far as risk of failure is concerned, yes, 25G cutting, that is a Quinky, will be having a better feel and less chance of failed spinal as compared to my 25G Whittaker. But that's a question of practice, and that's a question of making it comfortable, because there you are paying the price of increasing the risk of PDPH. So this is a very nice article which kind of gives you a little flow and ranking of which needle is best available in your setup and which needle you should use. One more small thing about using introducer for all these pencil point needles. The important thing is that if you use these needles directly on the skin is the most is the toughest path in your path. So you're already blunting the needle on the skin. So if you take an atraumatic needle on the skin, you're already making the needle tip bluntal and you cause a damage. Also, if you keep going and keep touching the needle with the directly with the bone, then you may kind of damage the tip. So if you use introducer, the introducer not only prevents the skin blunting, it also gives you the direction, and it kind of minimizes the risk of PDPH. So you should always use introducer when you're using this thinner pencil point needle. Ultimately, just this diagram I'm putting here, just simply to kind of show you that PDPH is something that you cannot predict, cannot prevent all the time, because you don't know what kind of hole you have created and what kind of CSF leak is there. So this is just like a little thing that no matter what you do, you can't prevent it. Okay, now what did I give the patient? 8 milligram, 0.5% heavy bupivacaine. I'm not going to go into the detail of this. You know, we have various local anesthetics, short acting, long acting, hyperbaric, isobaric, hypobaric. We've got carbonated, pure isomers, liposomal local anesthetics. Everything is available. And this is again becomes a theory or like a full lecture on local anesthetics for spinal. So I'm not going to go in detail. But our main thing is lignocaine versus bupivacaine versus ropivacaine, and nowadays chlorprocaine. I don't know, it's not yet available for us, but it's something that again is finding its way back for a short cases. So something that just you all must know and try and kind of make a chart or kind of have some kind of information about available local anesthetics, either for your theory or in the viva. Next is adjuvant. Opioid is the commonest adjuvant that we normally use. I again recommend this fantastic article, which gives a total view on all the adjuvants used. As Dr. Bhavani, a friend of mine, says that nearly everything except for tea, coffee, and coke is tried in epidural space. People are a little wary of spinal, but in epidural space, people have tried anything and everything. Some of the things which have got some beneficial values and some kind of backup scientifically are listed here, and this article kind of gives you detail of that. So you must follow and read this, because again, every adjuvant, if I talk about, will take a long time. Opioids are the commonest that we use. The other adjuvants are used primarily either to improve the block or to extend the block. So the role of adjuvant is to make 1 + 1 = 3, and that's what something that you should be remembering. However, there are practical problems, and again, this very nice editorial talks about drug errors. So when you try to mix, when you do a polypharmacy, you have to be aware of what drug interactions those mixers will cause in your syringe. If you mix 2-3 different different adjuvants with your local anesthetics, you have to be aware of the drug interactions and its kind of effect on the nerves. Also, Some people say that we will not mix the drug and we'll use 2 separate syringes. But when you do that, you are causing loss of CSF and maybe cause the poor block or failed spinal. So basically, these are certain practical problems in adding adjuvants to the spinal anesthesia or epidural anesthesia, and one has to be extremely careful in terms of reading out and making sure that you avoid drug error. Tranexamic acid has found its way in all our operation theaters thanks to the pharmacological push that every OT now has tranexamic acid in their OT, kept fortunately or unfortunately next to the bupivacaine. And there are multiple, I would say unfortunately only, because there are multiple reports of accidental injection of tranexamic acid into intrathecal space. And I am aware of one particular case where the patient actually was given tranexamic acid in a small nursing home where he, for a hernia surgery, and after 48 hours, patient actually died. So this is something extremely careful that you have to be, and make sure that you avoid drug error when you are trying to mix the drugs. Even if you're not mixing, of course, even you are beyond pure bupivacaine that when you're injecting, you have to be extremely careful about reading the labels. Okay. Now, what is more important? When you are injecting your spinal dose, free flow of CSF is extremely important because it is associated with a failed spinal. Okay. One second. So flow is very, very important. Now, why am I insisting on this? Is because of this. There is some with the design that you saw. That's why I put that diagram of the various pencil point needles that we have. With the design that you saw, there is something called riding the dura. When you're giving a spinal, this is the correct placement of your spinal needle. Because when you give a spinal anesthesia and when you inject through the nerve, you have proper intrathecal spread. However, when you are using or when you're riding the dura, you don't realize it because CSF will come. And when you inject, you will have loss of injectate. And this is what causes failed spinal. So free flow of CSF is very, very important as opposed to a dribble here, dribble there, aspirating, getting little air bubble, getting little negative. You should advance the needle a little bit and make sure that the CSF is dripping freely and flowing freely so as to prevent your spinal from failing. What is more important sometimes is this. And this explains how things can dramatically go wrong. When you are half riding the dura, when you aspirate, you will get a CSF and you will say, fine, I am in the intrathecal space because the dural flap gets sucked in with your negative pressure. However, in this situation, when you inject, what happens is that with your pressure, the dura flap gets pushed in and you have a complete loss of injectate. And everything is injected into the epidural space, your spinal dose, and this spinal is 100% going to fail. The worst is when you get a subdural block. And how do you get a subdural block? When you inject, if the arachnoid gets dissected, you will have a subdural block. And this is something that can be dangerous. So again, it is very, very important to have a proper free flow of CSF in order to prevent all these complications and a failed spinal. Now, the second last thing that is important in my notes is the attempt atraumatic? Was there any pain or paresthesia when you injected? Okay, because there are enough evidences and studies to show that multiple and traumatic attempts are connected or increases risk or are predisposing patients to have either spinal or epidural hematoma or infection or abscesses. Pain on paresthesia or paresthesia on injection can cause direct nerve trauma or injury to the nerves. So it is extremely important to note this and mention this in your diagram or in your documents. Again, I recommend everyone to read this article, NEP3. This is the publication from the Royal College of Anaesthesiologists in the UK, and they have compiled the list of complications and risk where infection and nerve damage as a major complication is something that has been shown to be 1 in 50,000 to 1 in 1,500. Permanent nerve damage as high as 1 in 50,000. Okay, so it is extremely important that you are honest. And you know, this previous slide of mine where I said you have to mention that whether it was a first attempt and whether there was any pain or paresthesia. A lot of people say, sir, we just write like that. You know, residents say, sir, we should always write no first attempt. And so it's true that one can kind of fool around. But recently they did one study. They had a silent camera in the OT when a neuroaxial block was being performed, and or rather spinal anesthesia was being given, and they checked the notes, what was written, and they found that 35 to 40% of the time when people did not get the spinal in the first attempt, or more than that, when there was paresthesia or there was it was not mentioned in the notes. And you remember one thing, this kind of articles are easily available to lawyers as well. So when you are not honest, when you're not accurate, and when you write something, it can get picked up or it can get always argued. So just something to remember, that you have to be very, very careful of all these things. And that's why it is again very, very important to stick to the midline and go to the lower level of the spinal cord L3, L4 or L4, L5 without worrying the risk of neural damage. There's one very common question that gets asked. A lot of people say that how common is foot drop after spinal? Actually, it's an extremely rare complication, and it is most likely not the direct nerve trauma unless you elicited any paraplegia, I mean any paresthesia or any pain on injection. If there is slightest pain on injection or see, when you do a spinal and as soon as the needle goes in, if the patient gets little paresthesia, you should wait. You should ask the patient which side, and you should make a note of it. Before you inject, ask the patient if there is a slightest pain, slightest discomfort, you do not inject. You stop immediately and remove that needle. With what I said when I said earlier, atraumatic needles are also not atraumatic to the nerves. When you're talking about atraumatic needle, they are so-called atraumatic to your dura in order to prevent post-dural puncture headache. They are not atraumatic. They are not Gandhiji's needle for the nerves. They do damage the nerves. And even if you don't inject, just by puncturing a nerve, you can cause neuropraxia or a slight amount of transient neurological deficit, which can go and last for 6 to 8 weeks, 6 weeks to 6 months sometimes. Yes. And unfortunately, supportive line of management is the only management. So vigilance and mindfulness at the time of performing and follow-up of this patient and giving them psychological as well as medical support while they are recovering is also equally important. Okay. Most likely, as I said, most likely these kind of things are not because of a direct nerve trauma, but because of indirect compression. Peroneal nerve is the most superficial nerve, and it kind of can get trapped in wrong positioning of the patient. Long surgeries, compression, patients in the wrong position, those stirrups, all those things can actually cause this kind of a problem. And that is what something that you have to prevent after giving spinal. Because after giving spinal, when the position is given, it is your responsibility to make sure that there are no pressure on the nerves, there are no pressures on the pressure points, and positioning is proper, because the surgeries can last from 2 hours, 6 hours, 8 hours, and a continuous compression can lead to transient nerve damage. So this is something that one has to be careful about. Okay. And finally, I check the level and I write down what was the level that I managed to get with my spinal. Now, why is it important to know the level? Obviously, with increasing medical legal litigations, pain under regional anesthesia is turning out to be, especially in our setup in the cesarean, pain during cesarean under regional anesthesia is turning out to be one of the major medical legal kind of issues across the Western countries. And hence it is extremely important that you know that your level is right. You identify your level, you check it before you allow the surgeon. So when do you check the level? Always, always, always assess the level before allowing the incision. Do not let the surgeon, because surgeons are restless people. The moment they've given the incision, they will not stop. Then if you say wait for 2 minutes, they will not stop. They'll just keep doing fiddling around something. So do not let them cut. Do not let them do incision before you assess and make sure that the block is right. How do you assess the block? Various modalities are available. Use of pin prick, cold, light touch. I don't like personally pin prick at all, because picking the patients, and when you pricking in the area where it is not felt by them, that's fine. But when the same prick goes on the shoulder or on the armpit area, is not really, you can't use them as a pin bag. So pin prick is not a thing that I like to do. Either you can use cold, whereby you can use ice, which again is not available easily, or just the light touch. There was a very kind of this study, I'm just trying to look for it. A level at which the patient first felt any touch was 2 dermatome coded to the level at which the first touch was felt. So basically, what they are trying to say is that ascertaining first touch by using just dull plastic needle cap or the rounded tip of a tongue depressor is quite reliable. Now, sometimes people just touch with a finger, that is a light touch. But when you touch with, as I said, a plastic needle cap, that also checks touch as well as pressure sensation. And what they're saying is that if the first touch sensation is felt at a 2 dermatome higher than where you want to have the block, then you can allow the surgeon to go ahead. There are certain important landmarks from surface anatomy which you all must know. Where is your T4 and where is your T7, T6, T10, T12? And this again is a little diagram which shows for which kind of surgery, what kind of sensory dermatome level block is required. Again, various factors affecting the level of the spinal block. It's like long, again, another 20 minutes talk, and we're not going to go much into detail. But obviously, I just want to kind of highlight site of injection is something that everybody worries about. And that's why they try to go higher as much as possible so that they can get a good block. But that's not always the right approach. As I already pointed out, L3, L4 should not be breached. L2, L2, L3 should not be your first option, should not be your easy go-to option. Varicity will obviously help the spread, and it will certainly help when hyperbaric solutions are used with certain position. Again, sitting position, you must remember that when you're using a spine in a sitting position, you will have a risk of difficulty in getting a high block if you're not prompt enough to make the patient lie down and give head low. If you do the spinal in a lateral position, you may have an issue of unilateral block or a partial, one side higher block than the lower other. So this also is very, very important to be kind of keeping in mind. Volume, concentration of the and dose of local anesthetic obviously is important. Speed of injection, barbotage is again that causes little churning of the local anesthetics, mixes CSF with your thing, and then can give you higher level of block. Orientation of bevel, I'll just show you in a while. But important thing is here that you must understand that the spine has various curvature, and you have to negotiate this curvature in order to get the higher block. And I recommend everybody to see this kind of video which is there on the net, which goes by the name of Glass Spine by Lane Carey. This is an excellent video which I recommend all the residents must see. This explains various ways a hypobaric or an isobaric or a hyperbaric solution will spread in the spinal cord with different position and how the block height can be achieved. Just one thing I wanted to show here is the bevel orientation when you're giving a spinal anesthesia. If, as you know, quinky or a cutting needle is an end opening as opposed to your pencil point needle, which are side opening. When you're using a pencil point needle, if you have a bevel facing upward, when you're injecting the local anesthetics, you can actually have a needle at a lower level and yet inject the local anesthetic as a higher level because of the jet that it creates, as opposed to when you're using a pencil point, a cutting needle, which is like an end opening. When you apply a force, you will still just get the jet in the same level. So this is one advantage that one can, this one point that one can use to their advantage by going at a lower level and keeping the bevel facing upward. So you can actually achieve a higher level, or you can use the same advantage when you're using a caudal block and put the bevel facing downward and try to block a lower level rather than going up and causing more sympathetic block. So this is something that one has to be aware of when you're using a pencil point needle. I'm not talking this bevel orientation from the point of view of post-dural puncture headache, because it really doesn't matter which way your bevel is, but it would certainly help you in getting a good block height. All right. I have actually almost said everything that I wanted to say about spinal. Kalpana, if we have time, I've got another 15-20 slides to go on epidural, certain small points that I want to highlight. Is it okay?
Yeah, please do go ahead.
Yeah, so that we can finish up both in one go only. Yeah. Okay. Again, this is not an anatomy talk, so I'm not going to talk about anything, but I have specifically put this diagram here to understand the clinical importance of the epidural space. Now, as you can all see, the epidural space per self is a triangular space. And this is very, very, very important to remember. And why is it that? Because if while performing an epidural, if you are in midline and if you reach up to here where you get your loss of resistance, you have a very big space to go put your catheter. However, if suppose you have entered from a side and if you're not in a midline, then your catheter has a very high chance of going out of the intervertebral foramina and not being in the epidural space. So again, this is to highlight that midline is very, very, very important to have midline approach. This can also mean that if you're not in midline and if you're going to come all the way here, you may find it difficult to thread the catheter. You may not have enough space to thread the catheter. And in that situation, if you rotate your needle, thinking that maybe, I'm abutting against something, if you rotate your needle, you may damage the dura and cause external dura puncture. So it is extremely important, once again, I'm trying to say, is that stick to the midline. This also is very important to understand that sometimes when people are doing CSE, they get a fantastic loss of resistance. They say, yes, I'm in the epidural space. But when they go with the spinal needle, they fail to puncture the dura and get a CSF. Again, it is because you have missed the midline, your epidural needle is lying here. And through this, now there is no bending, there is no kind of turning of the spinal needle. Spinal needle doesn't have a choice but to go through the same path And when it goes to the same path, it brushes out the dura and doesn't touch the dura, or just kind of mix the dura without getting your CSF, and you may not be able to give a intrathecal dose of CSF. So again, sticking to midline is something very important, and that's why I've just put this diagram here. Another interesting thing, when everybody talks about epidural, the most important ligament in our life is ligamentum flavum. The supraspinous ligament anchors the tip of the spinous processes. The interspinous ligament stretches between the spinous processes, whereas ligamentum flavum is the toughest ligament that lies deep to the interspinous ligament and forms the posterior border of your epidural space. Now the thing is, it has a variable characteristic, which is important to know because the thickness of this dura is different in different region. Dura is toughest in the lumbar space, but in cervical space, it is the thinnest. So it is very important when you're doing an epidural, you must know which region you are approaching and what is your kind of safety margin, I would say, of puncturing the dura. One second. Here is also very important thing is that dura is not like a continuous straight membrane throughout. There are natural gaps in dura, there are natural thinness, there are natural pockets in dura. And if you're unfortunate enough to reach exactly here, then you may not get the proper loss of resistance if your technique is not right, and you may end up not identifying that you've gone through dura, and you may cause dural puncture and end up with a major post-dural puncture headache with epidural. So that leads us to what is most important thing as far as epidural is concerned is the identification of epidural space. This again can be a short note. So just I made a little chart for the residents to kind of, have the vision of what are various methods available. There are visual methods, there are tactile methods, and there are auditory methods, and there are technological methods. With the newer technologies, a lot of other advances have been happening. Just for the sake of history, just certain diagrams to see what various usual, methods are. Those hanging drop techniques and, balloon, Macintosh balloon, and all those things are just there. This epimetic syringe is also one of the techniques. This diagram has recently been published in the IJ. Tasneem from Saifi, they try to make a little what we call Indian jugaad, put a little rubber gloves on the back of the syringe and try to apply the continuous pressure while they're going for the epidural with the continuous pressure technique. So various techniques are there. Here is one. You can just see this. Yeah. So various techniques are there to identify the epidural space, including this new electronic ultrasound guided and auditory techniques, where you just have these things connected, and as you reach the epidural space, suddenly the acoustic sound comes. However, of all this technique, the only technique that is practical and that what we use is loss of resistance, and that's a tactile method, and that's age old, and that's what I recommend all the residents to focus on. And now it's really very difficult to actually teach the technique of doing an epidural, but something that I practice, I'm open to arguments and people have different practice, and seniors who have been doing epidural will say that we have developed these techniques. But my point is, something the resident should learn is a technique that is foolproof in terms of preventing post-dural puncture headache, right? Or puncturing, causing accidental dural puncture. And what we practice, or what I practice, is what is the classic Doughty's technique. I'm going to go on to the next paper in a minute, but if you can just all focus on this, what I'm trying to show is that in this, you have rested your hand of the left non-dominant hand on the patient's back. So that is like a support system, like a little, break that will prevent needle from suddenly going in. With the same hand, with your thumb and finger, you hold the wing or the needle tip of the epidural and inject with the other hand. Now, this is the paper that I want people to kind of, go through and read as far as the technique is concerned. It's called Doughty's technique, where Doughty was a very senior anesthetist from the UK who taught personally the residents about how to do the epidural and various techniques to prevent PDPH. And his technique with his resident, there was a study at that time that his residents and the other residents, and his residents in first 2 months of their training period had dural puncture rate of less than 0.5% compared to the other group of residents who at the end of 6 months also had a dural puncture rate of more than 5%. So basically it's a technique where this was his original technique, the A, where he's supporting his back on the patient's back, holding the needle and letting this other 3 finger just relax. He describes, being a typical British, as he describes that the left hand should be like holding a teacup, having tea with the queen. So the other 3 fingers should be relaxed and, like that. And with the right dominant hand, he's pushing the plunger. He's pushing the plunger and advancing the needle. Whereas the newer technique, or what we suggest, is what they can now call son of Doughty's technique, is use of saline and pushing the plunger and not the barrel. Sorry, this was the barrel. This is pushing the plunger with the palm of your right hand. So when you're using this technique, you are only pushing the plunger of this syringe, which is filled with saline, and this left non-dominant hand is actually working as a brake or a barrier for the needle to suddenly go in. And you just keep holding the needle. And when you apply continuous pressure, as soon as the tip of this needle reaches the epidural space, which is like an open space, the saline walks in, your plunger goes in, the barrel doesn't move, the needle doesn't move, and you are immediately in the epidural space and you just stand still there. So it's an excellent technique which needs to be practiced and which needs to be kind of learned from the resident's point of view in order to minimize the post-dural puncture headache. One more point I want to make here is that what happens when you do a dural puncture with an epidural needle. The first reaction is pull it out. However, when they reviewed literature, they realized that this pulling out of the needle causes a lot of trauma. And they recommend that you must reinsert the stylet before you pull the needle out, because that open needle thing can cause damage to the dural fiber. So when the needle was reinserted, or rather the stylet was reinserted, the PDPH rate was only 5% compared to 16%, like almost 3 times higher when it was not reinserted. This also is important when you're doing a spinal. Though with the spinal, the bevel size is, the hole is smaller, the needle size is smaller, it can still do the similar kind of damage to the dura. So, but you can't be wasting your time in disconnecting the syringe and putting the stylet back, because then you cause loss of CSF as well as loss of injected. So what you should do is that when you're doing a spinal, once you finish giving the drug, maintain that pressure on the plunger of the syringe and pull the whole thing in one go, as opposed to disconnecting or pulling without. So this is what causes increased risk of post-dural puncture headache. Whereas, so you must insert the stylet. So if suppose I was to have an accidental dural puncture, I will not pull out the needle. I will put the stylet back and wait, because what is the damage here is the loss of CSF. So as long as you do damage control, you stop the CSF leaking, you have all the time in the world to think what you're going to do now. But just reflexively pulling the needle out is something that is not advisable. because this is what they showed in the electron microscope. If you can see that this dural fiber got pulled and the fragment came into here, and this prevents the healing. It works like a little plug in the hole, and it doesn't allow the edges to heal and causes a persistent post-dural puncture headache or increase the risk of post-dural puncture headache. So it is very, very important that we do. So you must rethink. Okay, now certain technical issues. What will you use for loss of resistance, air or saline? I mean, again, it's a debatable issue. I am a saline person and I have used saline. I used to use air. I was trained on air, but once I changed to saline, I will never ever go back to air. They say that saline is better. It reduces chance of dural tap. It reduces paresthesia. It minimizes the partial block. It has got less chance of PDPH. But meta-analysis and Cochrane reviews was that there is no difference at all. So it's a operator's preference. So again, I'm not going to push on whether one should use air or saline on these issues, but saline is still better, because if you use air and if you get accidental dural puncture, you have a risk of pneumoencephalus, because if you inject air, some patients can get sudden headache while you're doing the procedure. Now that's not post-dural puncture headache. Post-dural puncture headache doesn't happen on table. It happens after 24 to 48 hours. But if while doing an epidural, if you're using air, if your patient complains of sudden headache, especially if you're doing it in a sitting position, it is most likely that you've injected air into the epidural space, into the intrathecal space, and that causes pneumoencephalus. Also, there is evidence that saline reduces venous pressure. There is a study which was conducted where they injected, after detecting the epidural space, they actually injected 10 ml of normal saline into the epidural space before putting the catheter, and they found that the traumatic catheter or blood in the catheter was only 2% when saline was injected versus 20%. So it reduces venous puncture because of the epidural engorgement of the vessels. You may cause little venous congestion. This is again more relevant for us in obstetrics, because obstetrics patients have a higher congestion and tighter epidural space, but yet it can still be the same for everybody. So what are the strategies to minimize the intravascular placement of your epidural catheter? People say lateral position compared to sitting position, again because of the same principle that there is increased hydrostatic pressure, so more likely to puncture veins. Flush your epidural space with fluid. A single orifice catheter versus multi-orifice. If you have a single orifice catheter and if you puncture, you have 100% intravenous placement. Multi-orifice catheter, the first orifice itself is about 1.5 centimeter away from the tip. So even if the tip is punctured, you are not likely to be in the intravascular space, or you can actually pull out the needle catheter and still be out of the intravascular space. And do not keep catheter more than 5 centimeters. Okay. This is what I said: close-ended catheter, single-ended catheter, wire-reinforced catheter. Various catheters are available. We are not going to go into detail of this, but what I'm trying to say is that yes, accidental intravenous placement is something very, very important. Sometimes it can be revealed. Sometimes you go and you aspirate and you get blood, but sometimes it can be concealed, and you may feel that no, this is not blood. Sometimes when you use saline to identify the space, slight pink, oh no, this may be my saline which is just there. So you have to be very, very careful. Now what do? There is something called Shah's test. Shah's test is what I do for all my epidurals when I use saline. When you have to have your catheter flushed and primed with the saline before you put the catheter in. Once the catheter is in the epidural space, you see it's like a meniscus sign. When you all put neckline, and once the you are entering the blood, the jugular, you see the meniscus of the fluid falling, and when you put it down, the blood comes back. Same thing happens in the epidural space. that if you are in the epidural space, the meniscus of the free fluid of the catheter at the other tip falls down. And when you put it down below the level of the patient, that fluid freely flows back. So that's what I always check. And if you're not careful about what is, if you're not careful about your intravascular placement, you will end up with a local anesthetic systemic toxicity, because when you use epidural in a larger dose, especially for the surgical patient, you may have. So again, as a resident, you must know what is last. It's a short note or it's a long question. You must know what is last. You must know how to treat and how to, use intralipid and what is the dose of intralipid, and everything should be kind of, it's like something that you should be ready and prepared. But remember, if there is any doubt, always take it out and reinsert the catheter rather than taking chance that thinking that no, this could be this could be that. Okay. Now, just one quick this thing. If suppose I end up with an accidental dural puncture, what are the options that one has? You can abandon and say, sorry, I can't do this, and will recourse to some other method of anesthesia or analgesia, whatever your goal is, or withdraw the needle immediately. Now, I personally feel that both of these are not really the option that one should think, unless you can abandon. If it's an obese patient, you've been struggling for 45 minutes and you just can't get it, and GA is not that difficult or is not really an contraindication. However, what option that you or I would kind of have in front of me is that either I will thread my catheter into the intrathecal space, or I will remove the needle after putting the stylet, thinking about the situation, and then maybe resite. Or again, this we do more common for our labor analgesia, but it can be done for surgical situation also, that through the needle, give an intrathecal dose and convert it into spinal. And then depending on the situation, you can redo the epidural catheter if you need to have the catheter for your long duration of the surgery or for your post-op analgesia. So the options are either you thread it or you resite it. What would I do? As I said in the beginning, if I see the Niagara fall of my epidural needle, I will actually reinsert the needle, reinsert the stylet and wait and think. Will I convert to CSE? Well, it's safe, it's time tested. As I said, I will, give intrathecal dose, and then I will think of putting a catheter again. Or I will put intrathecal catheter. Now, why will I put intrathecal catheter? Because it provides immediately, you get on with the surgery. And there are, the most important thing is, there are evidence is coming out now. This is my slightly old slide, so I've said where is the evidence, but there are evidence is coming out now that if you put the catheter into the intrathecal space after an accidental dural puncture, the intensity of the post-dural puncture headache and the need for epidural blood patch is reducing. So a lot of places are actually advocating to put intrathecal catheter and convert that into a continuous spinal anesthesia. Now, but it's not without risk, right? The difficulty to thread, you can do direct neural injury, infection risk is major. You can inject wrong substance, and various, and it's not something that is without risk. So will you do it? Depends on practical points to consider. Is that something that you have to be considering in your own setup? Was the epidural doing easy? Can I redo it easily, or was it a difficult? Means after half an hour of struggle in a patient where GA is contraindicated, I have managed to do an accidental dural puncture. I will put the catheter and just get on with it. But if it's a straight, simple, 60 kg young fit patient, I will redo it. I will probably not put intrathecal catheter. What is the surgical requirement? What is my comfort and my experience? What is my infrastructure? Can I leave this catheter in the ward? Is it safe? Or should I convert it to CEC or a DPE? So depends on what. you don't cross your comfort zone. It is very, very important to be comfortable in terms of safety of the patient before you take any initiative like this. Okay, complication of epidural, again, list of it. PDPH is something that is very, very common. But again, if I talk of PDPH, it's a full lecture by itself, so we can't discuss much. But one must be aware that it's not without any complication. And in comparison to CSE, again, this is, I've just put this simply for the resident to, they get these short notes asked that what are the, compare spinal with the epidural or something like that. So just a little chart or something that you have to have in your mind, or this is something that may get discussed across the table, that what are the advantages, why would you do a spinal and why not epidural. So there's something to just be, so these are just a little thing that you should know and be aware of. There's one small last thing that I want to talk about is the entrapped epidural catheter. Once a year, I would say, not more frequent than that, but that also is quite a frequent thing, is that we get calls that sir, epidural catheter डाला था, अभी 4 घंटा हो गया, अभी catheter निकाल नहीं सकते हैं. And that's a very, very typical phone call that comes where the epidural gets trapped. So how do you remove this trapped catheter? When you're removing the epidural catheter, and this is for the residents because you all go on your post-op round and remove the catheters in the ward. If there is a slightest resistance, or you think that when you're removing the catheter, it is kind of pulling back, do not stretch that catheter. Do not pull or apply force. It should be just like a little, you just hold the catheter and should just come out smoothly, just like that, as if, you are doing a paint brush, like the way you paint your patient's back with that hand flow down, you just put the catheter and it should just come out like that. If you have to pull or apply any stretch, do not pull. Number one. Number two, these catheters have good tensile strength. So what happens is that if it is trapped somewhere and if you start pulling, you may get a give and you think, yeah, it's coming. But what's happening is it is actually stretching inside, which you can't see. And by the time you can see the stretching, you already reached the snapping point. So slighted more snatch and the catheter may snap inside. So do not pull. You can place the patient, try and find out whether the catheter was put in a sitting position or in a lateral position. Try to get into the same position of that patient, the way the catheter was put, and see by bending or curling of the spine, you are able to pull the catheter. You can apply continuous and a gentle traction, but don't pull it hard. Sometime what happens is that you can flush the catheter with a saline. If it has got curled up somewhere or it has got stretched somewhere, it can actually unwind itself and you can pull it out. Surgical removal is not really warranted. If suppose you pull the catheter and something is snapped and part of catheter is left inside and you've not seen the blue tip. So again, I tell all the residents, when you remove the catheter, the only thing that you have to make sure that you see the blue tip at the tip of the catheter to ensure and document that catheter is removed in toto, blue tip noted, so that you are documented and 100% clear that catheter has come out. It is really, really important to document. And if this catheter is snapped and stays inside, there is no need to surgically remove unless it is symptomatic or it is near a nerve. And you must discuss this with patients. You must document. There are medical legal issues that you have to be. So it is very, very important that the patient is aware of what is going on. But surgical removal is not required. I have not come across, maybe there's one paper, probably I think I read, where a surgical removal was required because the catheter tip was just near the nerve and in certain position or in certain situation, it was irritating and causing pain to the patient. But majority of the time, these catheters, they do come out. Okay, so this is something that you all must be aware of. There are references up to date. All of the British County residents have an access to up to date. These are fantastic articles. You can go through this and kind of read. And if there's any questions, anything, you all can ask me. Okay, thank you. I'll stop sharing my screen.
Yeah. Dr. Ketan, thank you. That was a real detailed, exhaustive lecture that you gave us, which is with your tips and tricks. And it's going to be really, really helpful to all the students and, of course, to everybody in the, who have joined us today.
Yeah,
I
I
have
could
one or two
complete the
questions.
task because it's a Herculean task to talk on
I
spinal
can
epidural.
imagine. I can
So I
imagine.
just kind of have covered certain points, and I'm sure I've missed out a
But
lot of things. And
just
if the
what we
seniors are attending,
just what we
they
wanted.
will think that what is so many things are missing out. So I'm sorry about that. But
No,
this
no.
is
Just what we
plainly
had.
meant for
Just
the
what we
residents
had.
to kind of have the practical tips.
Just what we had desired and aimed for in this class. So it was just perfect. Can I ask you a few questions which has come in the chat box? One is from Dr. Anil Parikh, who says that, can I pull back my epidural needle after accidental puncture of the dura till CSF stop coming and put the catheter?
I wouldn't advise that at all, simply because number one, when you do that, you are not sure if you are riding the dura. So if the tip of the tuhi is kind of half out, half in, and you aspirate and the CSF doesn't come, because I showed you in the diagram, if you aspirate and the CSF doesn't come, doesn't mean that you are not in the intrathecal space. You can actually push the catheter and the catheter can become intrathecal, or the worst is you might put a subdural catheter. So I wouldn't advise residents to do this at all. If you are going to withdraw it, you withdraw it completely. If you're going to do intrathecal, do it completely. So you be either this way or this way. Don't be in the middle. No, Anil, I wouldn't recommend that.
And Dr. Amla has asked whether what are your views on segmental spinals that have now been given at higher levels?
Yes, that's why again I said I didn't want to cover that because I want residents to understand what is basic epidural and spinal and where the spinal needs to be given. There are lots and lots of studies coming out with thoracic spinals and higher level spinals and segmental spinals. And all I can say is that if you know the anatomy, you know where you're going at a senior level, you can take the risk with the USG guided techniques. You may want to give it, but I would be very, very, very uncomfortable putting spinal anywhere above L2, L3. And fortunately, in my practice, I don't need to worry about that. So I'm not really, haven't had any personal or practical experience on putting it any higher level than L2, L3.
Okay. With this, I think maybe I can ask anybody for any comments, maybe from Dr. Dhaigude, madam, if she is here, or I think Dr. Parikh wants to ask one more question. Dr. Parikh. Would you like to type your questions or would you like to unmute and ask? Why can you not unmute? Okay, I've asked him to unmute.
Okay, I see in the chat, one second, Kalpana. I'd like to answer this.
Okay.
Dr. Rajesh has put in the chart that it is quite common for patients to complain of pain or paresthesia during needle insertion, and also quite common for anesthesiologists to have to redirect the needle or make extra attempt. Documenting this can prove to be admitting liability for any future complications, which might not even be caused by neural procedure. Is it really advisable? See, the thing is, what is advisable is what you be honest and document, because tomorrow, even if you don't document that patient had paresthesia, if that patient has a complication which you are saying that is not related to your spinal, but if a patient has a complication which is a neurological complication, the patient will say no, that when the spinal was being given, I got a paresthesia. And at that time, if the thing goes back and then when your documents are checked, it obviously, even though it is now you're saying that it's not related to my technique, it is obviously that you have hidden the fact. So that will make you more liable for further problems than being open and say, yes, there was a paresthesia. See, paresthesia happening is a known fact. The thing is, in medical legal issues, I mean, I'm not a medical legal expert, but the way I understand is that there is something known as complication, which is described in the book. So if that happens, it is not that you are liable for a problem. It is not able to diagnose, treat, and follow up that complication is where the problem arises. So if you say when I did, there was a little paresthesia on the right side, 48 hours, 24 hours later, you go and see that patient and say there was nothing, no problem, patient is absolutely fine, document it in the chart, you are out of it. Then if suppose something happens later on to the patient, you can say this is what was happening, this is what I've done, and this is what I've followed up. So I would say that documentation something is really, really important, because all these lawyers, they go back into the notes and, they just, even if suppose everything is done properly, they will find out little lacunas and, pin you on that. So I strongly recommend that not to kind of hide the facts.
Dr. Tushar Choksi, would you like to say something? You are unmuted and you can speak.
Yeah, Kalpana, I am very happy that Dr. Ketan Parikh has given a very nice lecture to the postgraduate. I would like to say two things. One is I am doing good practice in orthopedic surgery when the hip fractures and some traumatic fractures are there, where we have to give spinal anesthesia in the geriatric patients. So my practice is sometimes in geriatric patients are not able to give the proper position. So at that time, I have started my own practice since last 10 to 15 years to give something like small ketamine and midazolam before giving spinal anesthesia, where patient is slightly conscious, but cooperative in giving the spinal anesthesia position. So that was I want to share with my postgraduate student. And second thing, I had 2-3 times one of the complication with my own surgeons. Sometimes what our surgeons like joint replacement surgeons says, you just give spinal anesthesia, no other anesthesia should be given to my patient. So sometimes I confess that I have to poke 4 times, 5 times to my patients some in the past. But at that time, when I started telling that I want to give general anesthesia to that patient, but again surgeon said, no, you don't give general anesthesia, you give only spinal anesthesia. You tried and tried again. So I want to ask Ketan Parikh in this situation, what to do for that type of the situation.
I mean, it's Tushar bhai, wo tumne sua jawab babu. It's a very kind of practical issues and which you have to deal with your surgeon. I mean, I would say first thing is I would say that educate your surgeon.
Yeah, that's what I want to tell.
First thing I would say is educate your surgeon, make them realize, take them out for a cup of coffee, take them to the club, have a dinner with them, and involve their spouses also, so that they don't shout at you, they behave nicely. And basically now I'm just joking around, but my point is creating awareness is the key. And sometimes, yes, they have some issues in past. They've had some problems in past. Like I tell you one thing, when I came back from the UK in '96,
okay,
I used to work with one very eminent obstetrician, and her thing was for cesarean only give general anesthesia. Unless epidural is given for labor, then you can convert the epidural for cesarean section, but you will not give spinal for cesarean section. Period. It took me 2.5 to 3 years to change around and convince her that spinal is a better option than GA for the various reasons. When she came out that she had come couple of bad experiences with spinal, and then I showed her the data and said those kind of risks are so rare, and it's not, again, I don't want to kind of blame somebody, but they are all sometimes individual related, people who have poor skills or practice. So I took about 2.5 to 3 years, and to my surprise, after about 4 or 5 years, some other anesthetists who went to give cesarean to that patient for to one of her patients for cesarean section, she refused to let him give GA. He said, no, you have to give spinal only to my patient. So I'm glad that I could turn around. So I'm basically just communication. Yeah, Anil, I think you want to ask something.
I think, the last question we'll take from Dr. Anil Parikh, because we'll be running short of time.
Yeah, so it's not a question. It's one probably you must have talked. I little joined late. The consent is very important. The consent you must have talked.
Second, that was the first thing I said. Patient refusal is a big thing.
And the documentation of the vitals and the documentation of like platelets counts and all in individual. That's a very important thing. Third, a personal experience of a case where I was called to give intrathecal methotrexate, and this hematologist has told me to give methotrexate, and morning somebody, the hematologist himself, has tried multiple times, but when he failed, then he referred to me, and my shot was single, like L3, L4. And after 3 days, patient developed severe pain in the limbs and neurodeficit. Then we did an MRI and we found a huge hematoma in L1, L2 space, which was symptomatic after 3 days. So what I say is, as you rightly said, the attempts, whatever, it should be documented. And even like previous person, if you are done, and if you are doing another hospital, that's very important as documentation of attempts which you taught. Thank you. An excellent talk. There are a lot of tips I learned from you, Ketan. Thank you.
I think, Dr. Anil, you have made a very, very valid point. And Dr. Ketan, before we leave, Anish, our resident, has asked a very nice question. He's asking that, can we give spinal and epidural to patients who've undergone spine surgeries or instrumentation or anything? Any of your tips on that, Dr. Parikh?
Yeah, absolutely. You can give it. The thing is, you have to, first of all, I mean, starting with the basic, you have to preoperatively assess the patient. You have to find out what surgery is given, what instrumentation is done. You have to have a clear MRI pictures and, assess whether you have a window to get into the spinal epidural space. You have to document their present neurological deficiencies. And you have to have a discussion with them. You have to have, pre-op meeting with them and document every meeting, and let's discuss the pros and cons and find out why the spinal is mandatory, or is it that GA contraindicated and spinal is the only way out. And as I said, patient's refusal, patient's discussion, you can certainly go ahead with documentation and writing down everything. And in today's day and age, as I told you in the beginning, for you residents, for anything, anytime any question is asked, I will do it under ultrasound guidance. Is your final verdict, is your God's eyes. So, you can answer that way. But yes, the answer to your question is, can you do it? The answer is yes. How will you do it? Is A, by preoperatively assessing the patient, documentation, neurological assessment, documentation, risk benefit ratio, documentation, and MRIs and proper evaluation of the space, documentation, and then you can do it.
I think a very valid point. In fact, Dr. Parikh, don't you think this is one of the cases where you would definitely want to do it under an ultrasound guidance?
Absolutely. That's what I'm saying.
Correct. Okay, I think with this, we'd like to end today's session. And I thank Dr. Parikh for a wonderful talk. I've been seeing some very lovely messages in the chat box, which I'm sure even you are, and everybody's complimenting you. And they've really found this topic very comprehensive and very, very enlightening to them. And we hope to have some more lectures that we will be rescheduling again. I thank you all for joining us on this Sunday morning. Bye-bye, everybody.